And, so there's not necessarily a term written into the lease for renewal. The Board of Land Commissioners has limited the terms of leases down from 75 years, and it's very lease specific, project specific. And what they've said is the term of the lease cannot exceed 75 years because that's a limitation provided by statute. But it also can't exceed the economic life of the improvement that's built on the property. So a lot of our leases are in that 30 to 35-year range because that's the expected economic life of the project. When we reach the end of term, they can reapply for that lease and we essentially renew it, but it's a reapplication, it's a reconsideration, and the Board of Land Commissioners has the authority to insert new terms at that point or deny the lease altogether. So it's not necessarily a continuation or an outright right to continue the property use. The Board of Land Commissioners has to agree to it moving forward. And I think that's the limiting factor that some people with large projects have when they come and visit our office and understand that's the term that they're experiencing, is that there could be a no at the end of the tunnel and not an explicit yes, which is why we believe 99 years gives them a little bit more comfort moving forward.
Okay, thank you. Okay, question, Representative Baker.
Yeah, I just want to urge the committee to vote no on this and keep it with the proposed 99 years. And just to bring a little perspective in, a house that was built 75 years ago is in 1947. And as a realtor, we're selling houses regularly that are much older than that are from the original owners, that are from the family. And, you know, that's just a house. So that's not an apartment building. That's not, you know, a gaming facility or a casino or a hotel, anything like that. So I would just urge us to let's provide the stability with the 99 years. The 75 years is the current statute. We're not seeing a lot of it being abused currently. So let's just take that step forward and provide the stability. Thank you, Mr.
Okay,
Chairman.
are you ready for the question? Representative Hallinan, comment on the motion?
I have a question for the director.
Yeah, go ahead.
Do you customarily increase the price of the lease over that 99 years, or is that set one time and the lease price remains the same? Thank you.
Go ahead, Director or Deputy?
Mr. Chairman, Representative Hallinan, there's usually a 5-year sort of look, if you will, every 5 years look to see if that is a market rate. There's a CPI sort of component to that. If we need to increase, we will, but it's not set in stone forever and ever, you know, for the 75-year term or the 30-year term or whatever it is.
Okay, very good. Any other questions now? We got a motion on the table. Question. All those in favor of the motion to keep it at 75, please say aye.
Aye.
Those opposed, say no.
No.
That motion has failed. Okay, any other motions? That's at the bottom of that page 4. Going to move to page 5. Any other amendments, Representative Schuler? Senator Schuler?
That's quite all right, Chairman. Thank you. I'm going to go ahead and make an amendment, if it's all right, on line 6, page 5, to add in the language that was deleted with the exception of all, and then put a comma after zoning laws on line 7. I really think that it will help not only strengthen E, which I hope E stays in, but someone may want to amend E a little bit. But I think just adding that, taking away that all, and just put applicable land use planning and zoning laws, comma, all minimum standards adopted by state regulatory agencies, comma, and so on.
Very
So I would
good. Is
make
there a
that.
second? Second, multiple seconds by Representative Roscoe and Yin. Okay. Any more discussion on that amendment? Representative Gray?
Thank you, Mr. Chairman. You know, I'd like to encourage a no on this. I think, I don't think adding that language really back in does too much. I mean, I think frankly, the current language, I think doesn't do much because, I mean, there's always the question of what's applicable. And I think when you have a county or multiple counties, but really it is one county, that have written zoning regulation, I mean, that preclude any use, you know, and they say, well, you can't do any private school within this county or within this area. You can't, and they do the same thing when a proposal like the glamping comes around, they could say you can't do any recreational activity. I mean, I'm not sure that's what happened. I wasn't there. I haven't followed this whole situation, but having been in the legislature for, 6 years and witnessed the one aspect of the Teton County experience, I just think that, while I understand a lot of the perspective there, I just think removing the language is better. And I think there's still the question of what's an applicable, zoning law. I don't know really if this does much, but I just think it's better to keep, I do have an issue with the new language, but I think it's better to keep this in there. So I vote no.
Any other discussion? Mr. Co-Chair.
Mr. Chairman, thank you. I think I would join with Representative Gray, just to remind us that this is trust lands. And they're trust lands that we have an obligation that was given to the state of Wyoming even prior to the creation of any of these regulations with respect to these properties. And prior to many of the municipalities even encumbering these properties. So I hope that we would keep the language it is. I think we can really trust the Board of Land Commissioners to work with local officials and to try to do the right thing. So I encourage us to resist the motion.
Okay, any further discussion on the motion? Representative Roscoe.
Thank you, Mr. Chairman. I would vote an aye on this. It satisfies a lot of the county municipals and the stock growers concerned about adjacent lands. It's just by far better planning to have it this way. So I'd
Further
vote
discussion.
in favor of that. Thank you.
Thank you. Okay, on this one, I'm just going to ask for a show of hands. Ready to vote, I believe. So all in favor of the motion, please raise your hand. 1, 2, 3, 4, 5, 6. All those opposed, raise your hand. 1, 2, 3, 4, 5, 6, 7. That motion has failed. Okay, any other motions on page 5?
Mr. Chairman.
Representative Roscoe.
So, Mr. Chairman,
Representative Roscoe is who I recognize. Go ahead.
Thank you, Mr. Chairman. Is that okay? I propose an amendment that would add on page 5, line 12, after residential, comma, and add recreation and industrial.
Okay, is there a second? Second. Okay, so everybody understand the motion on page 12. I'm going to repeat it. After residential, comma, industrial, comma, and recreational. Josh got that. Okay. Very good. It's been moved and seconded. Any discussion? All those in favor of the motion, say aye.
Aye.
Opposed? Okay, it's been adopted. Any further motions on page 5? Representative Sweeney? No? Everybody good?
Thank you, Mr. Chairman.
Okay, you're good. Okay, go ahead.
On page 5, I'm not exactly sure where to address this, and maybe a question to the director. In testimony, we heard concern not consulting with Game and Fish. I'm assuming on any of this, especially, as far as corridors, those different things, you would automatically, OSLI would consult with the different departments, not just DEQ.
Director or deputy, any comments on that?
Mr. Chairman, Representative Sweeney, I think it depends. I mean, Game and Fish is not a regulatory agency with respect to development, with respect to what we're trying to do. But generally, we would be aware of corridors and that sort of thing. And we do look at that. We don't want to have any missteps either. So we do generally look, but it's not sort of in the mandatory language at this point.
Okay, very good. Any motions then on page 5? Okay, do you have a motion? Okay,
I do, but I don't know where, I would ask LSO if they have a spot that Game and Fish could be included. But I don't know where it belongs, Mr. Chairman.
Okay, Josh, and you kind of understand the concept, really require consultation with Game and Fish and corridors and those kind of, is that?
Yeah, Mr. Chairman, so I think probably on page 5, line 12, after shall, something like shall consult with Game and Fish related to applicable corridors or whatever, and then say and shall promulgate rules.
Right. Okay, is there a second to that motion? Okay, so Representative Roscoe, so the motion then is requiring on these leasing activities to also, and the word is shall, consult with Game and Fish. Okay. It's in the green line version on line 12. Board shall consult with Game and Fish. Okay, it's concept, everybody understand? Really the gist of the motion. Any further discussion? Okay, all those in favor of the motion, say aye.
Aye.
Opposed, say no.
No.
That motion has failed. Are there other motions on page 5? Representative Gray?
Thank you, Mr. Chairman. I would like on page 5 to delete, start at line 5, starting at including, down to line 9, ending at safety. So that would delete the new language in red.
And the existing.
Yes. But the existing gets merged into the new, so it's really the same.
So just to restate, it's after 36.5.117, comma, the delete starts
Mm-hmm,
through electrical safety on line 9.
mm-hmm.
Okay, is there a second? Second by Representative Jennings, is that a second? Okay. Any discussion? Go ahead,
Yeah,
Representative
Mr.
Gray.
Chairman, I just think until we get a description of what the Council on Fire Prevention and Electrical Safety requires, I would prefer for us, the other way I could have done this is just delete including the Council on Fire Prevention and Electrical Safety, but it's very broad. I think in session, we could come up with something, better in that area, but I don't know what all minimum standards adopted by state regulatory agencies, I don't know what that means. And especially when you include the Council on Fire Prevention and Electrical Safety, I think it's just better to give the board some discretion there. And I think it's a totally new concept from what was originally in that clause as well. So I'd prefer just to take it out before we can get an understanding of what exactly is required by the Council on Fire Prevention and Electrical Safety.
Okay,
Thanks.
thank you. I think Senator Baldwin has a question or comment.
Thank you, Mr. Chairman. More of a statement than a question, and that would be that I will be voting no on this amendment. I believe that those codes are well established. I think that everybody else in the state follows, and I think it would be a problem to not require them in this instance. I think that, if there's a question, then before the session, certainly somebody can go ask that question when it comes up in committee. Before it goes to the floor, we can get those questions answered. But it's my experience, those codes are solid. Of course, I don't think it's a secret. I work in the fire service. And those codes in electrical and fire are solid. They're required for all other construction in the state. And I think they're important. And I think they're important to include here for these folks that are going to be doing things on our state lands as well as everywhere else in the state. Thank you.
Okay, thank you. Any other discussion? Representative Roscoe?
Thank you, Mr. Chairman. I have to agree with Senator Baldwin that it's actually a public safety issue as much as anything else, not so much the building part of it.
Okay, any other discussion? Okay, we sensing you're ready to vote. All those in favor of the motion, please say aye. All those opposed, say no.
No.
Okay, so that motion has failed. Okay. Any other motions on page 5?
Mr. Chairman,
Is that Representative Sweeney?
yes.
Okay, go ahead.
So, Mr. Chairman, Mr. Magagna mentioned something. I didn't catch the full language on line 14. I'm sorry I didn't write fast enough or understand clearly.
Okay, I think it was on line 11 kind of, and I'm gonna, Josh just helped me with this too, and members of the committee, but when leasing state lands for commercial residential purposes, board shall promulgate rules, but then it was also in consult with full consultation or in consultation and consideration of the current lessee. That was really the gist of it, that, and I guess, Deputy, do you guys, I mean, if somebody's got a lease and there's a proposal to buy out that lease or change it, it's a process, you include the current lease lessee.
Mr. Chairman, you're correct. There is a process within the Board of Land Commissioners rules to involve them in the conversation through the lessee consent form. The only issue that I would raise with what Mr. McGagna brought up was if we don't get a response from that surface lessee, and that does happen, what he mentioned may limit us, just stop us right there because we didn't receive any comment from them. The Board of Land Commissioners right now understands that that's an outcome and has steps that they can take to consider the impacts for the lessee if they don't respond. But that response piece is critical, I think. If they don't respond, we need to have an avenue as well to keep moving forward if the impact is agreeable to the Board of Land Commissioners.
Yeah. So it's currently being done. Okay. And did you get a second? You got a second, or did you? Or no, we haven't made the motion. I guess I read it. You want to make that motion? Or not?
Yes, I believe I would, if I get
Okay.
it.
Is there a second? Okay, Representative Hallinan. Any further discussion? Go ahead, Representative Sweeney.
Thank you. I'm getting text, not from people in the room, but there's potential problems with this on the floor. I think that would at least get some buy-in from the ag community if we at least put something of that. I don't know if it needs to be that exact wording because I'm not trying to hamper if a current lessee doesn't respond. I definitely think there needs to be something in place to let the Board of Land Commissioners move forward.
Right. Yeah. Who is it? Representative Gray.
Mr. Chairman, could the motion be restated?
I think it could. I think it certainly could. And go ahead. You want to restate that or?
The only word I wrote down was current.
Yeah. So it's really requiring the board then to consult and consider the current lessee. Now, we know that's already being done. The question is, when the current lessee does not engage in the process. And so there's problems with it. That's the beauty of making statute. It's never that easy. It's more than one word. Okay, we do have a motion on the table. Any other discussion? Okay, all those in favor of the motion say aye. Aye. Opposed, say no.
No.
Okay, that motion has failed. Is there any other motions on page 5? Okay, moving to page 6. Okay, how about page 7? Page 8.
Question on the bill.
Question on this version of the bill. The green amendments are in here. And question on the bill. Member Shulkey, please call the roll. Emily?
Senator Baldwin? No. Senator James? No. Senator Pappas?
Aye.
Senator Schuler? Aye. Representative Baker? Aye. Representative Gray?
No.
Representative Hallinan?
No.
Representative Henderson?
Aye.
Representative Jennings? Representative Roscoe?
No.
Representative Sweeney? Representative Yin?
No.
Co-Chairman Case?
Aye.
Chairman Harshman?
Aye.
Mr. Chairman, we have 7 ayes.
So it is a tie vote. So this bill will not move forward as a committee bill. Representative Yin.
Mr. Chairman, so I think there are things that I really liked about this bill, but I think the biggest one of gutting local land use was the big killer for me.
So you don't want to change your vote?
I'm interested in doing something maybe with you together as a personal bill, figuring out where that middle ground could lay. Because I do truly want residential housing built on state trust lands, and I think we can find something like that together.
Okay, so Representative Roscoe?
Thank you, Mr. Chairman. I too appreciate the effort and think that residential housing would fit if we get it right, but the complexity of the issue, I think it seems like the county, the bigger players, maybe the county being the biggest, their concerns were not all resolved here. So when I had the working group, I reached out to all these stock growers, and I was really glad that the wildlife issue was brought up, that the Outdoor Council recreation was brought up, and the effects of these developments on adjacent land. And so I think it deserves to be at least an interim topic coming up, if we just kept that in mind, or I would work with somebody on a bill for discussion as well. Thank you.
Okay, any other? Okay, we are going to, now by our agenda, it's only 9 o'clock, but it is actually 10 o'clock. And a lot of folks are here for Medicaid expansion as our next topic. I'll just preface that it's the exact same bill that this committee passed last year. But we do have amongst us, we've got Representative Gray, Baker, Sweeney, Roscoe, and Hallinan, and Senator James. This is their last day of legislative meetings. So we got a little ice cream cake down in that garden break room. Gonna go down, and after a tie vote, we're gonna take a pause, go sweeten up, come back and work on Medicaid expansion. You're all invited to join us. I don't know if the cake's big enough for all of you. And we can cut extremely small slices, which probably would be good for us anyway. So with that, it's 9:59. We'll be back at work at 10:20. And you can follow me to the ice cream. Thank you. All right, let's go get some ice cream. Are we ready? Okay, we have a quorum. Are we online streaming? Okay, perfect. Okay, welcome back, members. And again, we're a little bit behind. This is the exact same bill that this committee passed last year. It is on the website. It was House Bill 20 last year. And with that, Mr. Anderson, if you want to take us through the bill quickly. And yeah, go ahead. Thank you.
Sure thing, Mr. Chairman. Josh Anderson, LSO. So yeah, as you noted, the bill we have is the bill that was sponsored by this committee last year, which was House Bill 20. I don't believe there would need to be any changes to it if you wanted to re-sponsor it this year. It just directs the director of the Department of Health, the insurance commissioner, and the governor to negotiate with the Centers for Medicare and Medicaid to obtain a state plan amendment to provide Medicaid coverage for all persons described under the Social Security Act. As noted there, it does provide that any expansion of Medicaid would not be administered during any time when the increased federal assistance is less than 90%, or during any period in which the regular federal assistance percentage is less than 55%. Repeals a previous bill that would conflict, and then it would become effective immediately. That's the bill, Mr. Chairman. Take any questions.
Members, any questions?
Yeah, Mr. Chairman.
Anderson? Representative Jennings.
Yeah, Mr. Chairman, I don't think in my packet I had that bill. Can we get a copy of that?
It's online.
It is posted online, Mr. Chairman. We can certainly get hard copies.
Sure.
Yeah, if I could
Go
get a
ahead.
hard
You bet.
copy, that'd be great.
I'm looking at it online here. If you go to the LSO website, it's online.
Yeah.
You bet.
I like paper, Mr.
Do
Chairman.
you? I do too, but I'm looking at it online right now. Any other questions? Okay, I'm gonna move to public comment on this bill. Are there elected officials here in the room that would like to comment on this bill? Any agency directors? I'm gonna move, are there elected officials online? Are there,
Mr. Chairman, we have Montana Representative Buttry online.
okay. Tell me the name again? Buttry?
Ed Buttrick. He was a senator, now he's a representative.
Okay, good afternoon, Representative Buttry. Can you hear us?
I can hear you, Mr. Chair. Can you hear me?
Yes, we can, Representative. So go ahead and introduce yourself and where you're from and how long you've been in this legislative business.
And we're glad you're here.
Yeah,
Thank you. Thank you, Mr. Chairman. I'm Representative Ed Buttrey. I serve as a state representative in Montana. Currently, I formerly served in the Montana Senate for 8 years. I termed out of that role in 2019, and I've since been serving in the Montana House of Representatives. I'm a business guy. I'm an economic development guy. We have a citizens legislature here in Montana, and so we only meet once every 2 years. But and I can give you a little bit of history of how I got involved in Medicaid if you'd like, and what we did in Montana. Would that be appropriate?
sure. I think you were probably the most closest, most similar example to our state.
Sure. Thank you, Mr. Chairman. Well, like many other states, I started serving in the Senate in 2011. And at that point, there was a large debate going on about Medicaid expansion. We had a pretty large divide in the Montana legislature. We had a governor that was pushing for expansion just under the kind of simple one-size-fits-all rules that the feds were proposing. We had a Republican-controlled legislature that was, in those initial years, focused on undermining any effort to do anything that resolves or anything similar to expansion. So we were in a real divide. And that's when I came into the Senate, and I'm a solutions guy, and I've always said doing nothing will accomplish nothing. And we all realized that in Montana at the time, we were 48th in the nation in poverty, and we had a large number of rural hospitals that were on the verge of collapse. And I just felt like we needed to do something. There's a couple key points that I think are undeniable that we all realized. First is that if someone is unhealthy or they're addicted, They simply are unable to contribute to their own or their state's success and health. And secondly, prior to expansion, the real entitlement already existed. The folks that would be affected by Medicaid expansion were already getting health care. They were simply getting it in the most expensive manner, usually through the emergency departments. And in many cases, they were getting that care for free, which was being cost shifted onto other folks, people that pay for insurance, on hospitals, on self-pay. So we felt, the group that I created, we felt like we needed to come up with a solution. We didn't have any qualms that we were going to come up with the ultimate solution. We wanted to do the best we could. We wanted to make sure that we measured the outcomes, that we adapted the program, and that we were constantly looking and gathering data to make sure that we had done what was best for Montana. So we set a large number of goals. I'm just going to go through a couple of the goals that I think would be relevant to your discussion. Our first goal was to improve the health of Montanans, both physically and mentally. And that would be, of course, including more access to substance abuse treatment. We wanted to bring as many Montana healthcare dollars that we were paying into the ACA back and put it into work in Montana. One of our main goals was to save our rural safety net hospitals and businesses, and our rural critical access hospitals were in dire financial straits. We wanted to provide a pathway out of poverty for our low income population. And again, we have to realize that a healthy workforce is a productive workforce. And if we could find a way, and this is what was really important to me as an economic development guy, if we could find a way to implement an economic development program as part of our healthcare solution, I felt like we would best serve our population. And we did this. And in fact, as we look back today, we created the largest, most focused, most successful economic development program in our state's history. So without getting into the specifics of our bill, I'll just talk a little bit for a moment about some of the results. And as I said before in the bill, it was critical that we measured the outcomes. So our Bureau of Business and Economic Research did a study in 2018, which looked at the financial and other impacts of Medicaid expansion in the first 3 years. And then Manat, who's a pretty reputable national company, did a study this year in 2022, mainly focused on the financial benefits. So as we've looked at these studies, as we sit here today, first of all, if we look at our non-financial benefits, we did see an increase in workforce participation of this population between 6 and 9%. And that, of course, is really good and supports our businesses and financial health of members. We did see a dramatic gain in opportunities for substance abuse treatment. We saw a reduction in crime of the population we were serving with Medicaid expansion, and that's been annually greater than 3%. We did show, and this was important to me, that in times of economic upturn, so when we look at the economic health of our state prior to the COVID and recession years, we saw Medicaid expansion and all of Medicaid rolls reduce over 10%. And this provided proof, at least to me, that if there are good job opportunities available, if we're providing some training opportunities to the population, that people will get jobs, and they then see less reliance on government social programs. And we found, as we thought we would, that this population generally wants to be successful. They want to work, they want to take care of themselves and their families, and we've seen that happen. We saw uncompensated care reduce over 50%. So in 2015, when we implemented the program, our annual uncompensated care for our hospitals was over $400 million. And currently it's down under $200 million. So we saw a half decrease in uncompensated care. We saw emergency department use by this population decrease. It's been decreased about 13% for medical emergency department uses and over 30% for dental emergency department uses. And we did see the overall health of folks in this population increase. There are certain categories that they determine people go into, and in the excellent health category, we've seen that increase over 5% per year. But bottom line, we knew that if we were going to have a program and we were going to be able to continue the program, we had to pay for it. And the cost currently to Montana is somewhere between $80 to $85 million per year for Medicaid expansion. That's our 10%. As we all know, the feds pay for 90% of the cost of the program. The state's responsible for 10%. So we had to come up with savings in the range of 80 to 85 million or more. We do this in a couple different ways. One is we've taken advantage of being able to move folks that were in traditional Medicaid programs, breast cervical treatment programs, medical needy, those type of things where we're getting a 65% match from the feds and move them into expansion where we're getting a 90% match. We have seen savings per year from moving folks to Medicaid expansion from traditional Medicaid, and that is anywhere in the past few years from $20 million to $60 million, which is about anywhere from 30 to 60% of our state share of cost for the program. If we look at programs within the state of Montana outside of Medicaid, we were able through Medicaid expansion to reduce state spending in mental health and substance abuse programs by about 2.1 million. We were able to reduce the cost of our inmate hospitalization, which formerly was done through medical contracts with hospital providers. Now they're part of the expansion population. That saved the state $10 million. That's latest numbers we saw was in 2019. So when you add those up, that paid for 17% of the $85 million of the state share of cost. And then, of course, we have increased revenues. We did this in a couple ways. One is we increased the hospital utilization fee as part of the way to pay for the program, because we knew that expansion would increase healthcare consumption, and it did by about 6% per year. So that increase in the hospital utilization fee to the state brought in about $14.6 million in 2020. That covered 18.6% of the state expansion costs. And then, of course, we saw economic activity and income increase due to Medicaid expansion. Latest numbers showed that we've created over 6,000 new jobs, over $400 million in new personal income, most of which is taxable, $700 million in new economic activity in the state of Montana. And so we add those together. The latest report by Manat shows that that's bringing in $43 to $46 million in state revenue per year, which is 52 to 56% of the expansion cost. So, Mr. Chair, when we add those numbers together, the bottom line is that we, through these Medicaid transfers, the savings outside of Medicaid, and the increases in economic activity, we have more than paid for the state share of cost of Medicaid expansion. In fact, when you look at the P&L for the state, it has been a positive impact to the state. We found and can show results that it's been good for the mental, physical, and financial health of the participants. And it's certainly saved our rural hospitals. Since we expanded in 2015, we have not had a single rural safety net critical access hospital closure in the state of Montana. So basically, the sky didn't fall. The state is still financially in great position. It didn't affect, as we've heard others say, education or any other state programs. We have made it sustainable, even at the lower federal match. It's completely sustainable to the state. And overall, we performed our job. We provided a service for a large portion of our population, and we've actually made it an economic positive for the state of Montana. So that, Mr. Chairman, that's a very quick overview of our program. I'd be happy to answer any questions that you may have. Appreciate the time to speak with you today.
Representative Buttrey, appreciate you joining us. And members, are there any questions of the good representative?
Mr. Chairman.
Representative Sweeney has a question.
Thank you, Mr. Chairman. Representative, I really appreciate the information. Do you happen to know your FMAP that comes back to the state of Montana? Ours here is only 50% match. And that's a point that's kind of in contention for us, but
I can help with that, Representative Buttrey. I think you guys now with the enhanced federal, you're at 70, but take away that 6%, you're about 64, I think. And I'm looking at a map here of our surrounding states. Is that about right? 64 is your normal?
Yes, Mr. Chairman, it's somewhere between 64 and 70%.
So and that's based on your average household income, that 3-year. What is that in Montana? Is it probably around 52 or 3 or something to probably get that FMAP is what I'm.
Yeah, Mr. Chairman, I don't have that exact number. I think it's actually less than 52 or 53, but
really?
I don't have that number.
See, our issue in Wyoming is, and the national average is 59. Well, Wyoming, we're 60. national or state average. So we're above the national average. So we have this 50-50 FMAP.
Right.
Well, the problem is Teton County is 220,000 average. And when you take them out of our FMAP, it drops us down to 53,000, 6,000 less than the national average, probably similar to Montana. And so, we're sitting at this 50-50 FMAP. And really our populations are real similar
Right.
to yours, certainly. So it's an interesting conversation that we're having about this, but okay. Any other questions, members? I think Senator James has a question for you, Representative.
Thank you, Mr. Chairman. I was just curious, how exactly did you guys make this sustainable?
Thank you, Mr. Chairman, Senator James. So sustainable meaning that we track the entire P&L. We're looking at how much the state is spending on this population, what the program is costing us, everything from the healthcare costs that we're paying to the administrative costs, and then ensuring that we're collecting data showing that the financial benefit at least meets those obligations. And as I've stated in my earlier testimony, that the benefit financially in the state of Montana has been a positive when compared to the cost. So obviously, when we started the program and the feds were paying 100% of the cost of the program, that was a no-brainer, but we had to ensure as the FMAP for expansion dropped that our revenues and the savings outpace those expenses.
Okay, Representative, just quick question, this 90-10 thing is a big deal. And, that's a big fear, I think, in our body that, well, that's just a promise and they'll drop it to 50-50 someday. And do you have those same conversations?
We do, and in fact, in our legislation, and I believe your legislation has got similar language, but there is trigger clauses in the legislation and statute that if that FMAP percentage were to drop, that either the state would have to agree to pick up the balance of how much that FMAP reduction would be, or the participants in the program would have to pay for that reduction through premiums or other payments, or it'd be a combination of the two. If the state was unwilling to pick that up through the legislative appropriation process, if we were unable to charge premiums to make up that difference, then the program would simply end. So we do have protection in the bill in case those costs exceed what they are today.
Okay, I think we have another question from Representative Henderson.
Thank you, Mr. Chairman. Representative, you mentioned a hospital utilization fee. What's the average fee across your state?
So we have different fees, Mr. Chairman, Representative, we have different fees depending on whether it's inpatient or outpatient. And so for inpatient stays, a hospital will pay a set amount per inpatient bed day. And then for outpatient, then they pay a percentage of the revenue that's generated from the outpatient. I don't have those current numbers with me. There's some formulas that are involved, but I'd be happy to provide that to the committee.
Okay, very good.
Thank you.
Okay, any other questions? Representative Baker has a question.
Thank you, Mr. Chairman. My question is about the triggers and your expanded population if it were to be triggered. What would the state's plan be to cover that expanded population if the programs were then stopped? Thank you.
Go ahead, Representative.
Thank you, Mr. Chair, Representative. And that's the trick is we don't know under the current CMS rules if the program were to change, and let's say that there were block grant funding or other mechanisms for bringing some of that money back into Montana. We would have to look at what that funding is and decide as a state who would be eligible for it, what the requirements would be, what the cost sharing would be, and how we would continue the program. We knew that if something happened at the federal level and the program were to go away, that at least with the years experience we have in the program, we could better identify who the most needy were. We've had cost sharing, we've had premium requirements in our legislation since inception of the program. We felt like we would have a good head start in creating a Montana-centric program, utilizing whatever funds were available. And it's just hard to know if the ACA were to be replaced, we don't know what that would look like.
Okay, I think Senator James has another question.
Thank you, Mr. Chairman. Representative, just out of curiosity, what federal guidance do you have that indicates the feds would let you out of Medicaid expansion if you chose so?
Go ahead, Representative.
Well, right now, we're under court decision that Medicaid expansion is at the options of the state. If the state and the legislature were to deny appropriations and spending authority for the program, deny the ability for the state to receive those monies in, then the program would simply cease to exist. If providers, hospitals were to provide that service, they would not be reimbursed through Medicaid for that population. So I think under the current court decision and law, we would have the ability to back out of the state. It's been done before. And we'd have to come up with something to replace it, probably something on a much smaller scale.
Okay, thank you. Any other questions, members? Well, Representative, we really appreciate you joining us from Montana, and you have a happy Thanksgiving, and we'll continue our work down here. Are you guys going into session this year? Do you go on odd years or even years?
Well, thank you, Mr. Chair, for the invitation and ability to speak about our program. We'll be in session on January 2nd, and that should continue at least through April. So we've just obviously finished the elections, and we'll be going into session. We've selected our leadership, and we've got about a month of time to develop our legislation. We'll be in session in January.
Okay, wishing you all the best. Thank you.
Thank you.
Okay, I want to move now, no other elected officials. I'm going to move to agency directors in the executive branch. Any other executive branch, come on up and introduce yourself. Thank you for being here.
Thank you, Mr. Chairman, members of the committee. Good to be with you again this morning. My name is Stefan Johansson. Can you hear me now? I'm the director for the Wyoming Department of Health. I'll be brief and sensitive with your time. As you know, this body and the governor's office over the years have asked the department to study Medicaid expansion, prepare a variety of different plans, which we've done. I won't go into the details of those going back to 2014. There's a variety of options with Medicaid expansion. This bill provides the department and the executive branch the authority to negotiate with the federal government on a Medicaid expansion plan that would be most beneficial to the state of Wyoming. Along those lines, the past several years, we have issued an annual report on expansion, really just focusing on, to the best of our ability, with a pretty innovative model for projecting cost and enrollment, what that enrollment and cost would look like, so that we can provide you all as decision makers with the very best data and projections that we can come up with on what this would mean for the state of Wyoming. We issued our most recent report in January of this year. As usual, we will issue an updated report. We don't anticipate this year that the projections will change very much, but we will certainly provide that again to you in January of next year, here in a couple of months. To that end, Mr. Chairman, I would say that analysis, our most recent estimates really show that Medicaid expansion in Wyoming would likely cover an estimated 19,000 individuals at an annual cost to the state of $11 million or $22 million on the biennium. That comes with approximately $177 million of injected federal funds because of that 90% federal match. And I did want to mention, Mr. Chairman, because as the representative from Montana alluded to, in the early days of expansion, the federal government paid 100% of the cost for the first 3 years. That's no longer available. Right now, the match for the expansion is 90% federal, 10% state. However, with the American Rescue Plan Act, or the ARPA legislation, I just wanted to remind the committee there is an incentive for expansion in that legislation, that for states that expand now, for the first 8 quarters or 2 years of Medicaid expansion, the state's traditional Medicaid program, so the Medicaid program we operate now, receives a 5% enhanced match. We did the analysis earlier this year. That equates to approximately $54 million of offsets to the general fund. Combine that with the $22 million biennial cost, it would be a net savings to the state of $32 million. But again, this is temporary for the first 2 years of expansion. And we have all of that detailed in our report. We are happy to go into the details or answer any questions.
Just real quick, sorry, Director, the 54 million was an annual number for 2 years.
Mr. Chairman, that would be total.
But the 5% FMAP equals about what? Just not doing a net, just
So,
on the
Mr.
regular
Chairman,
Medi-
the 5% enhanced match on traditional would be 54 million on the biennium.
on and by him. Okay,
Yes.
very good. That's my question. Thank you.
Mr. Chairman, members of the committee, like I mentioned, I wanted to be brief. You've heard from us numerous times on this topic. We're more than happy to answer any questions about our projections, about the report or the history of what we've done. Mr. Fuchs, to my right, who is our chief policy and data analyst, has done an excellent job over the years refining Wyoming's methodology for projecting what expansion would look like. And we did that intentionally because we saw so many states basically under-project what their enrollment would look like. I think everybody remembers the estimates we saw in other states, and you had quite a few more people enrolling in those early days of expansion in other states. We've refined our model to account for that, and to account for that very deliberately. So as your health director, I'm very comfortable with the numbers we have put in front of you. And again, Mr. Chairman, happy to stand for any questions.
Okay, just real quick, I'll lead up the 19,000 then in the projection. You can correct me. This is how I recall the report. Basically, 2/3 were women and 2/3 were working adults in Wyoming. That would fall under this 19,000.
Mr. Chairman, that is my understanding. I look to Mr. Fuchs to corroborate that.
Go ahead, Mr.
Mr. Chairman, Mr. Co-Chair, members of the committee, my name is Franz Fuchs, Chief Policy Analyst, Department of Health. Mr. Chairman, to your question, we estimate around 56% employed, so in round numbers, around 2/3, but it's a little less than 66.
56.
56% would be employed. And
And
with
then-
I think you're,
And about
we have to double check
2/3
on that.
women, or how about the male-female breakdown? I
Chairman, I
mean,
apologize,
because
I
like
didn't look it up.
yesterday, we ate in 2 different places here in Cheyenne. I ate with several of you, and I always ask this question. I ask it in Casper, ask it around Wyoming, and we get to know the server. I always say, how long you worked here? And they're like, and so we talk, and I say, I ask this question to everybody, but do you have health insurance? Not one, ever. I mean, so I think that's what we're trying to get at, these working adults who just don't have coverage, fall in this gap we talk about. Go ahead.
Mr. Chairman, I think that's 60% is largely, that's accurate.
Okay, thank you.
Again, Mr. Chairman, these are estimates again, so it's,
Sure.
once you start getting into these demographic slices, it becomes more and more uncertain, but that's kind of the central tendency for that estimate.
Okay, appreciate it. Okay, questions, members of the committee? I'm going to start, and I'm just going to work right around. Representative James.
Thank you, Mr. Chairman. So I'm just curious, for people throughout the state, are we trying to cover people that don't have the option for insurance, whether it be through an employer? Because I've worked for many different types of employer. Every employer I've ever worked for has had the option for insurance. Now we've had the option not to take it. I want to make sure that we're covering people that don't have the option for insurance. So
Question.
I just want to make sure that that's where we're headed here. Thank you.
Mr. Chairman, Senator James, a bit of a nuance here. So we estimate that there's 2 kind of populations that we traditionally talk about with Medicaid expansion. And one is below the federal poverty level. So what you typically hear folks say, under 100% of the poverty level. Those individuals, per a subtlety and a nuance of the Affordable Care Act, currently do not qualify for the subsidized private insurance on what we call the healthcare marketplace or the exchange. That's really the coverage gap population. The Affordable Care Act and expansion did, what the expansion population is, however, is in addition to that population, there's also covered 100 to 138% of the federal poverty level. And in essence, that would, if states expand, that removes individuals who may have been enrolled in exchange plans to go on to Medicaid. We estimate that 60%, about 60% of the population that Wyoming would cover through expansion would fall in that first group, under 100% of the poverty level, who currently, because of these different dynamics, do not qualify for that subsidized insurance. So, Senator James, I'm not sure if that answers your question, but happy to
Go
elaborate.
ahead. You have a follow-up?
Yes, I
Okay,
do.
go ahead.
Thank you, Mr. Chairman. So were you aware that someone making $250,000, $500,000 a year can qualify for this Medicaid and Medicaid expansion, therefore pushing out someone that actually needs it?
Is that the case? Go
Mr.
ahead.
Chairman, Senator James, that is not the case. We
Yes, it
would-
is.
Well, hold on.
Absolutely it is.
Whoa,
Mr. Chairman, thank you.
No, hold on, let's work, we're gonna work
100%
through,
true.
you spoke and asked a question, now we're gonna answer the question. Go ahead, Director.
Mr. Chairman, per the law, if states expand, the cutoff for what expansion would cover is 138% of the poverty level. If anybody had reported income of more than that,
Reported.
then they would not be covered.
Mr.
Okay.
Chairman? follow
Go
up?
ahead, yeah, and let's make sure we,
Thank you,
we're all in Wyoming now.
Thank you, Mr. Chairman. So when you report your taxes, you have tax write-offs. So when you write off your taxes, it brings your reported income down. So if you report income below 138%, you qualify. So you can be making $500,000 a year, but you report zero because of the legal tax laws that allow you to write those off. So you could qualify for Medicaid expansion and Medicaid. So therefore, people that actually need this won't qualify because they will be pushing out someone that does need it.
You know, I
Thank
think, the question is, is there just a cap on the number of recipients folks get pushed out? Or is it the 138% is the level? I mean,
Mr. Chairman, if I may.
is there only 100 spots? You know
Mr.
what
Chairman,
I'm
there's,
saying?
there's not a cap on enrollment, but to Senator James's point, I think what would help clarify is the way this would be calculated is what we call modified adjusted gross income, or MAGI. It was a formula that was put in place years ago that doesn't allow for that unreported tax income to qualify you for expansion. Senator James, I'm more than happy to follow up with you on this and provide you the detail and the writing on that. I would be extremely surprised if any state that has expanded Medicaid, or if we did in Wyoming, that you would see folks with that level of income be allowed to be on the program per the federal law.
Okay, I'm gonna start moving. Senator Schuler.
Thank you, Mr. Chairman. My question was, I think we have, 38 states now that have expanded. I think there's only one in the West now that hasn't beside us. I think that's South Dakota. Some of the states that you mentioned that had a little bit higher levels of participation than what you expected. I think you mentioned, did we say 17,000 or 19,000 you thought would, 19? I guess I'm wondering kind of where did they drop the ball on that in terms of the states that didn't quite have the figures quite right?
Go ahead, Director.
Mr. Chairman, Senator Schuler, it's hard to say. We don't have a straight answer for why some of those projections were undershot. But again, in our modeling, we tried to account for that experience of why. It could be demographic factors. There's interesting examples of certain states that did pretty dramatically under-project their enrollment, and then a state, like North Dakota, that really over-projected its enrollment. They did not see the enrollment that they, in the early years, that they had anticipated. So it's very hard to answer that with a straight line. Apologies for the frustrating answer, but there's probably a variety of factors there.
Okay, moving down the line, I'm gonna move to Representative Yin.
Thank you, Mr. Chairman. So I think South Dakota actually did just approve it on their ballot in 2022. So I think we are now the only state in the West that has not approved Medicaid expansion. Just can we reiterate on what the coverage gap is again? So if you want to get something on the healthcare marketplace and you are 139% of the federal poverty level, you qualify for an ACA subsidy. And then if you are less than that, you don't. Is that the situation that we're in right now?
Go ahead.
Mr. Chairman, Representative Yin, currently individuals above 100% of the poverty level per the Affordable Care Act qualify for the subsidized insurance coverage on the healthcare marketplace or the exchange. That's, again, an artifact of the Affordable Care Act, where the original law required Medicaid expansion, and then ultimately the court decision overturned that to make it optional for states. So the coverage gap population is really that population that is under the federal poverty level, but that also does not qualify for the programs that we do have in Wyoming Medicaid or Medicaid programs around the country that typically cover what we call family care populations. very low income people who are caretakers of either children or adults. That current eligibility for Wyoming Medicaid for that family care population is around 56% of the federal poverty level. So it's easy, for me at least, to think about the coverage gap population in Wyoming as those folks who are between 56 and 100% of the poverty level. And again, in crude terms, it's very low income. Under 56 to 100% of the poverty level, we're talking in the order of $8,000 to $15,000 a year in annual income for an individual. And we, again, all of that detail is provided in the expansion report. We're happy to reshare that with the committee. Representative Yen, I hope that answered your question.
Okay, just a question on the 100 to 138, and people that qualify for insurance on the exchange. Blue Cross Blue Shield, I think, is our only, and it's heavily subsidized. I mean, if you're at 100 or 105, and there's been some criticism, I think, of expansion, saying you're taking people who have insurance in the private market and moving them to Medicaid insurance. And I guess my thought on this, and maybe, but you're really taking them from one heavily subsidized program, government insurance pays for, government money pays for. Some people are only paying $5 a month for Cadillac health insurance. And so you're moving them from one heavily subsidized program, government program, to a government insurance program that's actually probably not as expensive. Your thoughts on that?
Mr. Chairman, that's true. I mean, what we see in Medicaid expansion because of the 90% federal match, and what we see currently on the federal exchange because of the heavy subsidies from the federal government for those plans, it is federal fund subsidized insurance versus federal fund subsidized insurance. Very, very different programming, absolutely. But it certainly is the case that folks who would qualify for those subsidies, and if a state expanded, would now be eligible for Medicaid, they would likely move over to the expansion pool. I will mention, Mr. Chairman, because I think it's relevant, as recently as last Friday, I was having a discussion with CMS. We are still trying to push to see if there would be flexibility for a partial expansion. Your committees and the legislature have debated that many, many times since 2014 of that would be potentially a middle ground. To date, CMS and the federal government have not approved a partial expansion, but I have sensed some potential flexibility there. I cannot promise that, but as you might recall, in the previous federal administration, there was some entertaining of, I believe Utah proposed a partial expansion that was ultimately approved, but the ballot measure in Utah favored traditional Medicaid expansion instead of that. The current administration has not indicated they would approve partial expansions, but I do think it's a worthwhile policy topic to continue discussing because of what you just mentioned. You have heavily federally subsidized private insurance for that population, or in states that expand, heavily federally subsidized Medicaid insurance. Why not have an option for states to do a partial expansion just for that coverage gap population? We continue to raise that issue. And again, I had that discussion just last week with our counterparts at CMS. So just wanted to make that a comment to the committee. We continue to explore that. I wouldn't hold your breath on it, but we'll continue to run that up
Well,
the
you know,
flagpole.
and not that, and maybe I'll be proven wrong, but in all these discussions, we've never had private insurance carriers come up and oppose expansion. And I don't recall that ever happening in any testimony. And I think, this movement of this heavily subsidized, many times high utilization population, it's an interesting thing anyway, so that's my stuff on this. I'm gonna quit talking. Anybody else? Questions? Representative Roscoe.
Thank you, Mr. Chairman. Director Johansson, since you manage the program, just going back to Senator James's question, do you actively pursue fraudulent accusations or cases?
Mr. Chairman, Representative Roscoe, we do both by federal requirements and state law. We have a program integrity unit that investigates and takes action on fraud, waste, and abuse. We also have a legal entity outside of the Department of Health, the Medicaid Fraud Control Unit, that pursues and litigates cases of fraud and abuse. on either inappropriate utilization, inappropriate eligibility, or inappropriate payment.
Representative Baker has a question.
Thank you, Mr. Chairman. I do appreciate the discussion, and I want to encourage you to pursue, being able to just expand that minimum population, because I think that's something that I could probably get behind. I think it's a good idea. But I just want to ask your opinion on, the difference in what the chairman has spoken of is shifting that cost burden and the two different types of subsidies. It would still seem that there's a big difference between the two programs, though, because with Medicaid, the deductible and things like that may be in the other programs aren't as high. And so you would think that the utilization in these other programs that have the deductibles and things like that would be a little bit less. Can you share your opinion on that? Thank you.
Go ahead.
Mr. Chairman, Representative Baker, another good question. It's, you're right that on the private insurance side, typically cost sharing is more levied than it is on Medicaid programs. Again, some nuances of what we see currently in the healthcare marketplace and the exchange. There's not only subsidies for the premiums on those private plans, but what the federal law put into effect, which are called advanced premium tax credits. It's essentially additional subsidies and cost sharing reduction subsidies that do limit that, especially when you go down that income gradient closer to 100% for the population that would be on the exchange. So to answer your question directly, in private insurance, you often do see that in additional cost sharing, where you don't as much in Medicaid programs. For Medicaid expansion plans, and over the years, we've developed a few for the legislature in terms of levying additional cost sharing like premiums, copays, deductibles, workplace activities, wellness programs. All of those additional components of an expansion plan would require what we call a waiver, either through Section 1115 of the Social Security Act or another mechanism with the feds. Some states have done that, imposed premiums on that population that are higher than what you typically see in traditional Medicaid. And some states have elected a traditional, straight Medicaid expansion. There's a variety of options on both sides. I will mention that waivers typically with the federal government, they're administratively intensive. So we've tried to be clear that while we can design plans with some of those components included, typically come with higher administrative costs just to manage that type of program like an insurance company would. And those administrative costs are, per the Affordable Care Act and Medicaid expansion, are not 90% funded, they're 50-50. So I don't know if that answers your question, Representative Baker, but happy to elaborate.
Okay, any other questions? Representative Sweeney has a question.
So this summer, I noted that the governor of South Dakota happened to mention around their trigger bill that she would absolutely support going to, after Medicaid expansion was approved by referendum up there, which is much easier to get that on the ballot in South Dakota than Wyoming. But because of the trigger bill and because of Medicaid expansion, she totally supported healthy moms, healthy babies. And without Medicaid expansion, do you believe we have coverage that's extended? I know recently we approved postpartum care for, I think, 9 months or a year. But without Medicaid expansion, do you think we have a chance at trying to take care of some of these vulnerable moms and babies?
Mr. Chairman, Representative Sweeney, just a quick point of clarification. The Labor Committee did pass a committee bill to extend postpartum coverage for our currently covered Medicaid pregnant women group. That has not been approved fully by the legislature. We'll see that this session. to your question about without expansion, do we have the ability to provide care for that type of population? And the answer is mixed. We do have a variety of programs in the Department of Health that target low-income women, pregnant women in Medicaid and in our public health programs, mental health, substance abuse funding, very specifically for those types of services that the population you're referring to would be eligible for. To be clear, Medicaid expansion is a coverage extension. And so you've heard me say this, this committee and others have heard me say this multiple times. We often neglect the cost of healthcare is extremely high nationally. It's extremely high in Wyoming. Any additional coverage, whether it's through subsidized private insurance, whether it's through Medicaid, strictly on the financial side for individuals, can be a huge component to their financial health. I think it's less clear in the evidence what expansion does for physical health. Not to say there's not evidence there for improvement, but it's less clear, I think, in areas where that's been studied. But healthcare is greatly expensive. So to conclude, Representative Sweeney, I think Medicaid expansion is an option. It's a policy option that the state has that would increase basically insurance coverage for a population that currently doesn't have access to that type of affordable insurance. To say that Medicaid expansion is a comprehensive solution to maternal and child health or the health of that population, quite frankly, I think would be an exaggeration and an overstatement, and in my personal opinion, not healthy to the discourse. However, it remains clear that health insurance coverage for individuals and families' financial health and their general well-being is a huge part of this discussion.
Any other questions? Okay. We'll let you go for now. No other state agencies here. What we're going to do, folks, so it's 11:14. We'd like to now hear from folks who are opposed to the bill. And if you would line up, or do we have anybody online that is opposed? I want to hear from those against, and then we'll hear from those for, and then we'll close public comment and go from there. Nobody opposed? Is anybody here opposed to the bill? Wants to speak against the bill? Okay, all those in favor of the bill can start lining up to speak. And I would just say on our, brevity is, and we appreciate you and being here. And so we want to hear from you. And so you could just fill those 4 chairs. We're going to open this up to public comment. If you want to comment on the bill, those in favor of the bill, come on forward.
Or raise your hands if you're for it. That's
Yeah,
good too.
how many folks in here are for the bill, really? Yeah, okay. If you folks want to speak, we'll listen. So come on up, and brevity is always appreciated. And
It's really appreciated today.
since we're so far behind, but that's okay. We appreciate you being here. Just go ahead and fill these chairs, and then when you're finished, you can leave. You just keep refilling them. We'll just move as quickly as we can, and here we'll start right here. Go ahead.
Thank you, sir. Josh Hannes with the Wyoming Hospital Association, and I'll be very brief. Couple things, and I would just direct your attention again to the Department of Health's report that's available to you. A couple of things that I'd like to highlight in addition to the $32 million in net savings over the biennium that could be used, in fact, to pay for Medicaid expansion into a next biennium. There's also an estimated reduction in the cost of insurance on the exchange, and that's been borne out by the evidence in other states. I would echo Montana's experience. If you look at the objective analysis of other expansion states, their experience is quite similar. And then one of the other things I would just like to mention, so in Wyoming, as you all have probably heard from me, is that we have about $120 million a year in uncompensated care that we deliver. The experience from other states has shown that rural hospitals, which basically all of our hospitals are rural, stand to benefit the most from this. We have hospitals with 12 days cash on hand. We've lost a nursing home this year. We have seen decreased services. We've lost OB services in a few places, and we've seen over the years the decrease in mental health. Mental health is an area I don't know that we've talked a lot about, but expanding this service so that people can access the type of services they need to deal with their mental health and to receive treatment is critically important and needed in our state. And I think that's been an emphasis of this legislature and our governor most recently. So happy to answer any questions, but that's it.
Okay, I have a question by Mr. Henderson.
Thank you, Mr. Chairman. Are you able to tell us if there's objective information in those states or from those states that where this has occurred in terms of beneficial aspects of lowering the total cost of healthcare? In other words, people who have access to the care because of insurance coverage, how does that translate over their total area of health coverage in terms of cost?
Mr. Chairman, Representative Henderson, I'd be happy to point you in the direction of some analysis from those states, but generally speaking, and I don't think anybody would argue this point, that insurance coverage is critical to access, and more importantly, access in the right place at the right time. So without insurance, often you'll see people with severe acute conditions show up in the emergency room, which is a very expensive place to receive care and an inappropriate place to receive care. And having insurance, Medicaid, commercial payers, whatever, that drives your care in a preventive way and makes the front door of the healthcare system a primary care provider's office, which is less expensive and more appropriate, particularly for older adults, so between 45 and 65, who have chronic conditions.
Okay, very good. Thank you. Appreciate your
next
questions. Yeah, go ahead.
Mr. Chairman, I'm sorry, but I'm thinking we might do a housekeeping check here because we have the next topic listed as beginning before lunch, which would be the tax exemptions, the government tax exemptions. And I'm thinking we're not going to get to it before lunch. It is carried over into the afternoon. So, and I don't know when we'll start again in the afternoon, so pay attention, but I would think that we're not going to get to the government tax exemptions this morning. Would you
How
agree
many,
with me?
and how many folks shot in the audience are here for that governmental tax exemptions?
Well, I think the Department of Revenue hasn't showed up
Yeah.
yet. They're watching online, I'm
Yeah.
sure.
Okay, very good. Thank you, Mr. Chairman.
Thank you. So
Okay.
let's not do that before the afternoon. Thank you.
Very good. Any other questions? Senator James.
Thank you, Mr. Chairman. I was just curious, how much on average do the hospitals have in their foundation to be used for charity services?
Go ahead.
Mr. Chairman, Senator James, I don't know. Foundations are typically, and again, I hate to generalize because it's different. Foundations are typically raise funds in service to the health system. So purchasing large pieces of equipment, for example, right? So I mean, I guess.
Clarification, Mr. Chairman.
What's that?
Clarification. So, Mr. Chairman, these foundations are specifically meant for these big surgeries that people can't afford. So these are these foundations in hospitals for these particular type of services. All hospitals have these foundations. So I was just curious if you happen to know on average how much they keep.
Mr. Chairman, Senator James, so the answer is no, I don't know how much money these foundations have in savings, but I would also say they're not, the foundations don't serve the purpose of covering the gaps in a hospital's balance sheet, right, to drive to the bottom line. They're in service of special projects, purchasing pieces of equipment. What you'll see is hospitals that are delivering a great deal of uncompensated care have negative margins at the end of the year. There's a lot of red ink on their paper, on their financials.
Okay.
I mean,
Okay, any further questions? And I'm gonna go to, okay, Representative Jennings, got a question?
Thank you, Mr. Chairman. I do have a question. So yesterday we had testimony here that part of the hospital problems is entire wings are shut down because we don't have staffing. So can you explain to me how if we adopt Medicaid expansion, which is lower cost to the hospitals, but we can't even get staffing, how in the world, how does that help? How are you going to resolve the staffing issue?
Go ahead.
Chairman Harshman, Representative
I
Jennings.
think that reference was to the state hospital and Lander. I think that was, the reference yesterday was that an entire wing of the state hospital was unstaffed.
That is, Mr. Chairman, the main thrust of it, but we hear all the time that they can't get staffing in hospitals. Everybody's competing, just trying to find the traveling nurse or mental health help. We see that in Title 25 all the time. We just can't get people here.
Go
So
ahead.
explain to me how putting in a program that pays less helps incentivize getting more staffing.
Chairman
Go ahead.
Harshman, Representative Jennings. So I think the first thing I would say is that, yeah, Medicaid does pay less, but what you'll see in our Department of Health report is that a majority of the people that would fall into this currently don't have insurance. So when they show up to the hospital, they're not paying, zero. They're not paying anything. So the net revenue to providers is positive. So there would be more money coming in on a fee-for-service basis to our providers. Does it solve the workforce issue? I don't think it does. What you'll see in other states is that, and I think the representative from Montana alluded to this, is that the additional federal funds opens up more job opportunities, particularly in healthcare, but in other services in your community. So does it solve the problem? No, I'm not making the argument that it does.
Okay. Representative James.
Mr. Chairman, thank you. So you're suggesting that doctors are going to take on more patients for less money? So because the Medicaid patients pay less, doctors, I see all the time, they get reimbursed far less from Medicaid patients than they do from other patients. So to make up that additional revenue that they wouldn't get from a non-Medicaid patient, they'd have to take on more Medicaid patients to make up that difference, from what I'm understanding you're saying.
So, well, just a second, Mr. Chairman, if you don't mind. So this is the Hospital Association. He can talk about hospital things. The Medical Society is here and might be able to talk about doctor things. I don't know. But I think the basic point has been that more than zero is better than zero for compensation. And I think that's why the Hospital Association is supporting it. But you can talk to the Medical Society about the doctors.
That's a great segue, I think. Thank you. We're going to move on to the next. Go ahead, introduce yourself.
Good morning, Mr. Chairman, members of the committee. Sheila Bush with the Wyoming Medical Society, and we represent physicians in Wyoming. And I'm happy to answer your question if I'm able. Representative Jennings, I really appreciate your question. It has a lot to do with what I wanted to talk with you all about today. We've discussed this issue at length. And so I wanted to take a really narrow and specific focus on just one aspect of what Medicaid expansion would mean for the state's medical community, and that's access to care and physician shortage. So right now, just kind of painting the picture of what physician numbers look like. The American Association of Medical Colleges just released a study that by 2034, we'll have a shortage of 17,800 to 48,000 just in primary care across the country. For specialties, that shortage looks like 21,000 to 77,000 across the country. In Wyoming, that means a different study came out that by 2030, we'll need 104 more primary care physicians just in our state to take care of our existing population, which doesn't really account for a lot of the other growth that might not be able to be estimated. I bring that up, and I bring up physician shortage because Medicaid expansion is a critical component of our state being able to recruit future physicians to the workforce. Just recently, I think within last week, you saw an editorial written by the medical students here in the state, and it was a group signed letter desperately asking for the state to take a positive move on this issue. And it's because your physicians in training right now want to go back and practice in states who have demonstrated valuing healthcare. As Josh and the Hospital Association said, we want care delivered in the right place at the right time in the appropriate way. Physicians do best And even if you take in the components of burnout and fatigue, physicians who are able to practice and see patients early and diagnose conditions early and provide that treatment are happier physicians, and it expands their ability to take care of more people when they can deliver that care appropriately. And so seeing a patient or seeing multiple patients far too far down the line of a condition that was undiagnosed or untreated makes the practice of medicine a really, really hard endeavor. And so when they are able to see those patients preventatively and take care of health early, that's the way care was intended to be delivered. And Dr. Hallen, and you know this better than anyone, and I appreciate your nodding with me. And so I think when you talk about recruitment, Medicaid expansion estimates it'll create 1,900 new jobs. In states that have expanded Medicaid, they saw a 5% increase among internal medicine specialties on salary. That's significant, a 5% increase in salaries, in those states that have expanded Medicaid means a lot. It means a lot in recruitment. It, again, demonstrates the investment that the state has in healthcare. Wyoming has invested a great deal of money in training our medical students through WWAMI. And now those exact same students are literally begging for this state to step up and expand Medicaid so they can come back here and practice in an environment that looks similar to the way they're being trained across the country and all those other states who have expanded Medicaid. I will finish by giving you an example of our residency programs. As you all know, our residencies are they're educational health centers, so they're part FQHC on the clinic side, and they're training facilities under our university on the residency side. 20% of that residency population would qualify for Medicaid expansion. Right now, that patient population within the residencies currently qualifies for the slide 1 on the scale. And so to give an idea, 20% of that residency population is between 3,000 and 4,000 patients being served by Wyoming's residency program. Just to give you kind of it's rough math, but on a sliding scale at that one level, an average visit might be between $100 and $120 reimbursement. If those patients were on Medicaid through the federally qualified health center enhanced reimbursement, that same visit would look more like $370. So the math on 370 times 4,000 is pretty easy, but it gets you to $1 million real fast. And that $1 million can provide other services and can expand coverage, can increase faculty salaries for those physicians working in the residencies. So I recognize time is short, and I'll wrap there, but the Medical Society is strongly in support of this. Our physicians feel very strongly about it, and our future physicians feel strongly.
Representative Baker has a question.
Thank you, Mr. Chairman. I'm just curious about the narrative that you're presenting. So you mentioned that there could be 1,900 possible healthcare positions that would open up with expansion in the state. The Transportation Committee just heard testimony recently about the skilled nursing facility that's going up in Buffalo and how they're having a hard time recruiting individuals to come staff that facility, but they're also, the local community is having a hard time because they're fighting against now the state has needs and the private sector still has the same needs. So I guess what I'm wondering is, do you have any data that would show that states that have expanded Medicaid have there's less of a burden on their healthcare needs? So a state that has expanded Medicaid, are they more successful really in recruiting the amount of doctors that they need? Do you have some hardcore evidence that would show that it's been successful?
Mr. Chairman, Representative Baker, yes. So in the states that have expanded Medicaid, they're seeing improvement in physician recruitment. The idea is if you can allow your current physician workforce to care in a more appropriate way for the existing population, you're going to help recruit new physicians because you're recruiting to a state that can pay more. There's more predictability in that pay environment. You have fewer people who are cash pay You have more people who are accessing care early, so you're diagnosing conditions earlier, which is a cost savings to the state. And if you're creating an environment where it's better to practice medicine and your existing workforce can thrive, they won't retire as early. You're seeing mass retirements right now for a variety of reasons, but they won't leave the workforce or burn out as quickly, which is a huge component of the physician workforce conversation.
Mr. Chairman, could I just follow up?
Sure.
I'm just curious, and you don't have to provide them to me now, and I'm not trying to be adversarial in any
No, no,
way.
no.
I'm just curious.
Sure.
Is there some numbers, some data that would show that, hey, one physician services this many people on average across the nation, and in states that have expanded Medicaid, they are servicing this many, or in states that haven't expanded Medicaid, they're servicing this many? I would just like some data, not some, I mean, I follow the hypotheticals. I agree with a lot of them, but I would just wonder if there's some data out there. Thank you.
Go ahead. Okay, Senator James has a question.
Thank you, Mr. Chairman. I was just wondering if you might be able to provide some numbers that show whether or not these positions that you're saying that are showing up in these states are government positions or private sector, because one costs taxpayers additional money and one provides revenue to the state. So I was wondering if you might be able to provide those numbers as well to us. Thank you.
Okay, Representative Jennings has a question.
Thank you, Mr. Chairman. Mine is a little bit different. I want to tag on to Representative Baker's just a little bit. You have the statistics in the West, in the rural areas of this country, because part of the problem is getting people to move to Wyoming. It's just a problem. They come and not all of them want to ski. And so do you have some numbers on more specifically to the rural states? Because it seems to me like that's the bigger problem.
Mr. Chairman, I'll take the second question first, and then I promise I'll answer yours. So I think what we know about physician recruitment is that a large percentage of them will ultimately land and make a home in the same state in which they train. And so I think it underscores the importance of our residency programs in the state. Because Wyoming is a rural frontier state, we do better recruiting physicians who are trained in rural frontier settings, which again underscores the importance of our residency programs. And so expanding Medicaid, and that even, rough, very gross estimate of $1 million that would come into those residency programs, along with the state's generous support of them, helps train more physicians in this state who will then stay in this state. We want, it's why WWAMI is so successful, right? You're taking Wyoming residents, people who were raised here, who already love our state and know our state. You're training them in the very best medical facilities and bringing them back and incentivizing them heavily to come back and practice here. And the more that we can do to support that program and answer the calls of those students, which are largely in favor of expanding Medicaid, and the more that we can do to support the residencies, which also looks like expanding Medicaid, then the more capability they have to train those medical students and residents, because we know statistically they're the ones who are more likely to come back and practice in this state. It's not taking a kid who was maybe raised in Manhattan and trying to convince them that the mountains here are beautiful, right? And I hear you, and it's why this is so important for us, because it does sort of underscore and further foster the programs we have in existence. Your question.
And perhaps new programs.
Yes.
Should be in existence.
And I'll quickly, so the American Medical Association does a number of studies on the economic impact of physicians. These would be, I think that, I don't have a breakdown of what percentage of the positions would be government funded or publicly funded. I think it's an even harder question to ask or answer when you think about the breakdown of our even community facilities. Some of them have components of federal funding, state funding, right? Like it's a pretty interesting picture. But I think what you're really asking is, what is the economic impact of even if we recruit one physician, what does that look like? And so the American Medical Association has long done an economic impact study. I can share it with everyone in like a really simple one pager, but I think the big takeaways are, right, when this study was done, they studied 875 Wyoming doctors practicing in the state. Those 875 doctors supported 8,547 total jobs that were supported just by those physicians. 4,320 of those were direct jobs created by the physician practicing. So that's an average of 9.8 jobs per physician is created by that person. So $1.5 billion in total economic activity is generated by physicians. 1.8 million is the average economic total generated by physicians. I can continue, and I would love to share this with you, but I think it's really compelling data, and I think it goes to show how all of these pieces fit together and how it compounds in a really positive way when you do the right thing on the programming end.
Thank you, Mr. Chairman. How many Medicaid patients did those doctors have?
So in Wyoming, 99% of our physicians all see Medicaid patients. And it's a mix, right? So most of our physicians have a patient population that's a mixed, they have everybody from cash payers to commercial payers to government payers. And almost all of our Wyoming physicians see Medicaid patients.
But how many?
Specific, like per practice?
Like if there's a number, do you have a number that the state or the doctors that you referenced in that number right there, how many Medicaid patients contributed to the dollar amount that you just quoted?
Okay, now let's work through the chair. Here we go.
Mr. Chairman.
So the question, just restate, I'm going to restate what I think are, really, how many Medicaid patients do doctors see?
Mr. Chairman.
You said all the doctors see them, but what percent is that? How many?
All feels scary. That feels like a really good way to get attacked for saying the wrong thing, but I would say 99%, which feels better. So I can tell you it changes by specialty. So our pediatric physicians, I know here the clinic in Cheyenne sees 72% Medicaid of the pediatric clinic. So a really large percentage. If you work your way across the specialties and you get into subspecialty surgeons, you're going to see a very small percent, sometimes 3 and 4% of those surgeons see Medicaid as a portion of their patient mix. So I think it depends on what kind of specialty and what you're really after.
Go ahead.
So I think I'm just throwing out numbers here, they're not real. So 75% is private funding, then 25% is the Medicaid, then this percent is, or whatever, is Medicare, something like that. So that way we know Medicaid is contributing to that percent of the dollar figure that you just quoted. That's what I'm after here. That's what I'm trying to figure out. A pie.
Mr. Chairman.
Yeah.
I
That
think
makes sense?
it does. It makes sense. I don't have that number prepared for you. I can tell you, again, I can just repeat sort of, I know across the specialties, you're going to see a wide difference from your primary care, especially pediatrics, to your subspecialists. And so if you wanted to pick, I could try and work with my peers and pick a couple of primary care and pick a couple of subspecialty and get that number to you if that would be helpful.
Mr. Chairman, if you
Go
want to
ahead.
break it down in compartments, that'd be awesome. I love compartmentalization. If you want to do a general, percentage, that'd be awesome too. Just want to know what the Medicaid percentage is that's contributing to the dollar amount that you quoted, so that way we have an idea of what the base amount is. And then when Medicaid expansion hits, we know what the additional amount is.
I appreciate that. Thank you.
Any other questions? Okay, we're gonna, thank you, and okay, we're gonna move on to other folks who want to speak in favor, and then so it's 11:40, and we're gonna complete this bill one way or the other before we break for lunch. So go ahead, introduce yourself, where you're from.
My name's Reverend Robert Gerard. I'm not here to preach a sermon, so it won't be 20 minutes. I'm a retired pastor here in town. I served First Presbyterian Church for 13 and a half years. And in that time, I visited 5,000 people in hospitals and 5,000 people in nursing homes. I saw a lot. I saw everything from people covered by Medicaid and how that helped them to sustain their lives. I saw people who did not have that coverage and how they died earlier because of that and suffered more. I would go to their houses or their trailers, and they were barely making it, any kind of a living whatsoever. And healthcare would have helped some of them to live longer. They had diabetes, they had lung diseases, they had all kinds of things that went on that were part of that. So I saw both sides of Medicaid and Medicare and all of those helping people out, and I saw where people had nothing and how they lived less of a life, which was sad to see. First Presbyterian Church would adopt 7 children and pay their health insurance through the year, and they wish they could have afforded to do more because that was expensive to do. But those were children who would not have had any medical insurance at the time that we were doing that. I don't know if they're continuing to do that now or not. I had a brother who lived to be 52, had Down syndrome. He lived in Pennsylvania. I saw what Medicaid did to extend his life. He should have died at 22. He lived to be 52 because Medicaid was there to help him out and help my parents out with that. So I'm bringing the human face to that. I'm the president of the Family Promise Board here in Cheyenne, and we take care of children who are homeless and their families. And we help them get educated again in what it means to run a household and to find a job. And Medicaid helps to cover them so they're healthy enough to take the education we offer and to get the jobs. And usually within 8 weeks, somebody who has been homeless, and it's usually because of medical problems, we have them having a job, they may be under Medicaid, and they're back out renting a place or finding a place, they're no longer homeless. So I've seen all these human faces and all this variety of things. And I think the Medicaid expansion has to happen because there are a lot of people out there who don't have what I described, that kind of care that gives them a better life. Thank you very much.
Thank you, Reverend. Appreciate you being here today and all your service. Appreciate you. Any questions? Reverend, thank you.
If you need visited at a nursing home, call me. I'll be right over.
Thank you. Any other folks want to testify on the bill? Okay, not seeing anybody.
Anybody online?
Anybody online wants to testify?
Yes, Mr. Chairman, we have Hollis Hackman online.
Okay.
Good morning, Mr. Chairman. Can you hear me?
Good morning. We can hear you and see you. Thanks for joining us.
Very good. Dr. Hollis Hackman, I'm the legislative chair for the Wyoming Psychological Association. I have an ill family member, and so I want to thank the legislature for the opportunity to provide remote testimony. And I hope we can continue to have this kind of resource because it can be very important. The Wyoming Psychological Association has supported Medicaid expansion bills from the beginning, because generally we're going to support any bill that reduces regulatory barriers and increases access to care, especially in the mental health field. And we think this bill does exactly that. That's what we thought a decade ago. Now, the difference is 10 years later, we're learning a lot about just what this means in terms of real services to people. So we heard from the representative from Montana earlier, and he touched on a lot of things that have to do with economic impact, and I think that's vitally important. But he didn't really get into some of the details about what's happened with behavioral health services in our neighbor to the north. And so I'll just touch on that briefly. I shared some of this at the governor's mental health summit where I was one of the panelists. But just since 2019, or by 2019, in Montana, somewhere north of 30,000 folks who were expansion enrollees had received outpatient mental health services. Also by 2019, almost 10,000 of those folks had received substance use disorder treatment. By 2020, and this is all findable on the Montana Hospital Association website. By 2020, nearly 34,000 people had received a behavioral health service who otherwise wouldn't have received it. Resources for substance use disorder treatment increased by over 70% Funding for prevention services doubled. The number of substance use disorder provider locations that are recognized by the state also doubled from 2016 to 2021. So in terms of behavioral health services, what we have seen in our neighbors to the north is a pretty impressive increase in access to care. And so I would just close by reiterating, we're going to support any bill that reduces regulatory barriers and increases to access to care, especially as relates to mental health services. So with that, I would stand for any questions. Thank you, Mr. Chairman.
Hey, thank you, Doctor. Appreciate you joining us. I think Representative Sweeney has a question.
Thank you, Mr. Chairman. So, Dr. Hackman, unbeknownst to you and me, I had clipped illegally out of the Casper Star your editorial piece and provided it to the members. That's the gold sheet. But in your opinion, then, if we did expand Medicaid, there really is greater services available on mental health and the issues surrounding that, whether it's homelessness or whatever the situation. Do you believe it also could help with our suicide rates?
Mr. Chairman, Representative Sweeney, absolutely. Our problem with suicide in the state has a lot to do with access to care. And if we can increase access to care for folks that need help and that are vulnerable, the outcome ultimately is going to be their improved mental health. And I think also there would be a reduction in the suicide rates that we're seeing in our state.
Okay. Any other questions of the good doctor? Okay, any other comments, Doctor?
Mr. Chairman, once again, thank you so much for allowing remote testimony. And I'm grateful to the legislature for allowing such, and I hope they continue to do so down the road.
Okay, appreciate you. Thank you. Thanks for joining us. Okay, anyone else online? Okay, no one else in the room. Okay, we're going to go ahead and close public comment, testimony. Members, it's been moved by Senator Pappas, seconded by Representative Henderson. Okay. We'll just work the bill, page 1, and move into page 2 now, where most of the bill starts. Any amendments? Page 2. Okay, any amendments to the bill? Okay, seeing none, please call roll on LSO draft 2 and Medical Opportunity Act. It's actually House Bill, or former House Bill 20.
I think we have some.
Do you have a comment? Oh, I'm sorry. Go ahead, Doctor.
Well, thank you, Mr. Chairman. I'd like to make a statement of my opinion on this bill. I think that we have an opportunity to deal with these issues on a state level. And I think that's the way we should have done it. We had a bill some years ago. I think maybe Chairman Harshman may remember the bill. The bill was the Frontiers Medical bill that was proposed by Senator Scott. And that allowed the state to provide the funding for a unique program that was going to provide some incentives for people to provide for their own medical care. And I think that is the better way to go. I think that the Medicaid expansion bill is likely to end up being a liability for the state because 90% is paid for by the feds now. But the likelihood is that it'll drop down to what the Medicaid coverage is for the poor, which is 50%. I don't think there's any good reason why the Fed should pay 90% on people who have some ability to provide medical treatment for themselves when they pay only 50% for those people that are too poor to provide any medical treatment for themselves. So with that reason, that's the reason why I'm going to vote no on this bill. I do believe that there is definitely a need for medical coverage for people in our state, but I don't think this is the best way to do it. So for that reason, I'm a no on this bill. Thank you, Mr. Chairman.
Okay, thank you. Representative Hallinan, anyone else? Mr. Co-Chair?
Mr. Chairman, thank you very much. I'm glad we're here today. It's kind of been a journey for all of us. I didn't used to support Medicaid expansion. I'm glad I do now, have for a while. My good friend, Dr. Hallinan, makes great points. We have tried other things. We haven't gotten anywhere. It hasn't worked. There are a couple of overwhelming things that I just come about. One is that all the providers, hospitals, psychiatrists, medical society support this. They want to help people that they see and will be seeing, and that's powerful. I know that we have some very good industries in Wyoming that take great care of their people. The mineral industry comes to mind, and folks that work in there, and like Senator James, I know he's worked in that industry, and they have great benefits. Those folks are well paid, and I mean, they do a great job. I work in the tourism industry. I own a hotel. And the tourism industry is being asked to pick up, we're supposed to be the future as we go forward. You keep hearing this, that the mineral industry is maybe in decline, not this year, thank God, which is another reason we can afford this. But our future is going to be different. And I'll tell you what, the people in the tourism industry, they don't have a lot of benefits. The tourism, the restaurants, the visitors, those services industry, I don't give my people health care. I wish I could. You can't afford the hotel room I'd have to charge for, honestly. And you couldn't afford the hamburger you'd have to buy. Yet these people are so brave and they're so struggling. And despite all, they hold these jobs and they try to do the right thing. And healthcare is just a huge challenge. It's a big lift. And if mom's sick, the kids aren't getting ready for school, they're not getting the extra treatment they need, and it goes on and on and on. And it's not about emergency rooms. If I break my arm and I don't have insurance, you're going to be okay if you go to the emergency room. It's all going to work out. You're going to, But if you have a chronic disease that needs management, which everybody gets eventually, it's inevitable. And if you're poor and you have a chronic disease, well, then the disease is not managed well. And you maybe have a little bit more absenteeism at work, your social interactions decline, your other things decline, and it's just a downward spiral. I'm looking at people in this room, Mr. Chairman, and next year in June, I'm going to qualify for Medicare. Pretty excited about that. It's going to be, I've had a rough road with insurance at different times in my life. And I'm really funny how magically these very conservative colleagues of mine, when they turn 65, they qualify for Medicare. And yet at the same time, they're trying to say that someone who's working hard, having kids, struggling in a single parent space can't qualify for Medicaid. I don't see much difference in them. They're both pretty socialist programs. A lot of things are socialistic. to make our society better. I look around at Wyoming, I see that we are very conservative. We are the most Republican state, the most conservative state. And in our region, we have grown the lowest of any state surrounding us. Our gross domestic product, if you don't count this year, had actually declined over the past 10 years. And our population grew the slowest of any of the surrounding states. Why is that? Some of it is about quality of life. And a lot of quality of life is how people are doing. And Medicaid expansion will help people do better. Employers want it. The business community wants this. Medical community wants this. The financial incentives are incredible. Could it all vaporize and go away? Well, for 10 years, this has been available, and it hasn't gone away. We missed the boat on the 100% F match, or 100% expansion. We have 90% expansion. It's been solidly there for years, and if it goes away, according to this bill, we're done with it. Courts have upheld that opinion. If we can't afford it, we can't afford it. We'll come to that then. We're sitting on record money right now. The $11 million that it would cost to fund this expansion, we demonstrated benefits just with the discussion from the Department of Health, more than $50 billion. I mean, that's just in the direct costs. That's not having more productive people to go to work, to show up on their shift, to raise their kids in a better thing, to give their kids more attention. It's none of that. Man, we need to do this. And you know, there's a tortuous path ahead through the legislature, but this will send a big statement out there. And I'll bet you, I've talked a long time. I didn't change a single vote on this committee. I didn't change a single mind out in the room or on the Zoom. Let's just get this done. The people of Wyoming support this. The polling supports it. Republicans support it. I'm ready.
Okay, Senator Pappas.
Thank you, Mr. Chairman.
Senator Pappas.
And I won't ditto everything from my good colleague here, because I agree with 100% of what he said. Other than the fact that I've supported Medicaid expansion since I've gotten
You're
into
smarter than me.
into the legislature. I believe it's the right thing to do, both economically for our state and for the people in Wyoming. If we have a healthier population, we're going to get more productivity. And God knows we've been looking at growth in this state. How do we get growth? We need to build what you mentioned yesterday, Mr. Chairman, livable communities. They want good healthcare. They want good education systems. They want good culture and arts. They want recreation, entertainment, all of that. That's what keeps our young kids here. So this is just a piece in economic growth in my book. It's like a no-brainer. And we've turned away how many billions of, almost $1 billion, right, over the years? Over $1 billion. Money that we could have gotten easily, and our population would have been healthier. And the key thing about it is, this money is appropriated by Congress, right? By giving it up, we're not like going to reduce the debt. It's going to some other state. It's going to some other program. We as taxpayers pay federal taxes. You know, I'm not afraid of, and certainly we as the state are not afraid of taking federal money, right? We take more federal money per capita, I think, than most states. So I believe that we should actually expand this program. It's good for our economic growth. It's good for our health of the population, and it's good, as we just heard, for recruiting a workforce as well. Thank you, Mr. Chairman.
Schuler?
Thank you, Mr. Chairman. I'll keep it brief. I think these last couple of folks have really hit the nail on the head with a lot of things I was going to say. But the bottom line is, I think the last poll I saw was about 70% of Wyomingites support this. That should matter to us. In fact, the last time that this came up, I kind of kept track in my own emails, and I had about 200 plus that were in support of it and about 20 that were against it. And if we're here to serve our constituents, that should matter. I vote on things sometimes that aren't maybe the thing that I want. In fact, I voted against Medicaid expansion last year because it came in as a budget amendment, and I didn't really like that. But for the most part, I just think it's too important a bill to look at it in the budget. But I feel like it's important to our constituents. And not only that, I really am concerned about our hospitals. I grew up in a small town. There's 4 little small towns in my district, and even the only place where we do have a hospital, they're struggling. And all this uncompensated care that gets written off every year, some of these hospitals, as was mentioned, are likely to go under. We've lost some care with OB and so on and so forth. Nursing homes, we need all of the health care we can get in Wyoming. So I've been supporting of this, not just for the savings, not just for the money, but for our constituents. Thank you.
I'm going to keep working this way. Representative Roscoe.
Thank you, Mr. Speaker. In my last committee meeting in my tenure, I think the last 3 narratives I heard from senators, I'd like to represent the House a little bit. Some of the best I've ever heard in my session. Thank you, Mr. Smirkin.
Okay, thank you. Anybody else moving this way? Representative Baker.
Thank you, Mr. Chairman, and I also appreciate the discussion. It's been a long discussion, and I think back to Tony Ross, who used to talk about how he attempted and tried to get the open container bill passed, and it took him 10 attempts. And I think that, as those 10 attempts worked through the process, they got better. And I think that that's what's happened with this bill also. And I think that there's an opportunity moving forward with what the director said to maybe even cherry pick even more, that our resistance in expanding may have put our state in a better position where we can negotiate in good faith with the federal government and get the best deal possible, where we can just focus on that, the 56 to 100% population that it really is a need that everyone is really concerned about. And so I want to encourage the committee to continue to move forward with those discussions, but I don't think that this is the right bill right now. I think that our resistance is actually, like I said, put us in a better negotiating position with the federal government, and to be able to see the mistakes that other states have made and adjust our numbers. As we've seen, the numbers have gone a little bit up based on the original projections, and I think it's been more accurate. Unfortunately, people have had to suffer in the meantime, and I don't have an answer or a solution for that, but I do have sympathy. Like the co-chair, I've struggled with insurance and fought that battle as a self-employed person, and continue to fight that battle. I have sympathy, but I think that we're not, all isn't lost because we lost 100% match. I think that we still have a good opportunity, and there's potential even in this session to adjust this bill to make it something that is palatable, that can really, like I said, put us in a position where we can cherry pick. So thank you, Mr. Chairman, for the opportunity.
Okay, thank you. Anybody else on this side over here? Okay, I think our comments are finished up. I'm not going to add to it. I've voted against this probably 10 times. I kept learning in the legislature, and I've learned, and I think, as I look back, I've changed my mind. I've learned more, and I think it'll be really good for our state. I think it is appropriate to put it in a budget amendment. We put policy in the budget, and so if it comes that way as well, I think that's wholly appropriate and the right thing to do. So anyway, so I appreciate everybody's work on this, and as we head to lunch, and so with that, we'll ask for a roll call vote then on this bill. Please call the roll.
Senator Baldwin. Aye. Senator James.
No.
Senator Pappas.
Aye.
Senator Schuler. Aye. Representative Baker. No. Representative Gray.
No.
Representative Hallinan.
No.
Representative Henderson.
Aye.
Representative Jennings. Representative Roscoe?
Aye.
Representative Sweeney?
Aye.
Representative Yin?
Aye.
Co-Chairman Case?
Aye.
Chairman Harshman?
Aye.
Mr. Chairman, that passes.
Okay. Okay, thank you. Okay, appreciate all the members. Yeah, we'll hold our applause, I think. Thank you.
Yeah, but
I-
I'll tell you something,
Yeah.
they do receive our gratitude for
Yeah.
being measured in your tactics today. Very nice job. Thank you.
Well, and I appreciate all the folks who've emailed and commented and showed up. Appreciate you. So we'll keep doing the work, keep moving forward. Okay, so we're gonna recess for lunch. It's 12:07. How about 12:30? Does that work?
12:30, 1:30.
That's what I said, 1:30?
1:30.
12:07, 1:30.
1:30.
Thank you.